thanks again, everyone. I'll just kick off. So we've got a great list of speakers today. Everyone's going to maybe talk for 5 minutes or so. It's just a quick run through. This was kind of inspired by a special themed edition for the Irish Journal of Psychological Medicine. It started around last March, and Fiona McNicholas and Bláthnaid Gavin approached me about a special issue. They said we could have a nice little special issue. I thought this was a brilliant idea. And within about 10 days, we had 50 submissions. So Fiona and Bláthnaid did an enormous amount of work getting lots and lots of submissions. And it's been very worthwhile. It's kind of put a lot of interesting perspectives in the public arena. And I'll just, in this presentation, I don't have much time, but I'll run through the perspectives from my editor's perspective, and also I've been a general adult psychiatrist in Wicklow Mental Health Service during this time. So I'll give perspectives from those two possibilities. Okay, so as I mentioned, COVID-19, it's possibly the most profound effect on global society since World War II, impacting nearly every element of society. And widespread lockdowns, which is a kind of a first really in our living memories, have imposed major challenges. And I think population mental health has been affected in many ways, and I'll discuss that in a bit more detail. Brendan Kelly is on the line. He submitted a very interesting paper on the history of major events such as the Great Irish Famine and the Spanish flu. So I'll let him talk about that maybe a bit more. And more recently, there's been kind of some slightly similar events such as the severe acute respiratory syndrome, or SARS, and the Middle East respiratory syndrome. And evidence from these, when people researched longitudinally after, suggested increased depression, anxiety, post-traumatic stress disorder. In terms of, I think Dr. Pat Devitt is on the line as well. He's written a very interesting perspective on suicide rates during previous major events. And I think one of his findings was about economic recessions might be a big risk. So I'll let him talk about that more as well. So we all recall the early effects of COVID-19. There was initially definitely a sense of anxiety, uncertainty, panic, lots of WhatsApp messages going around. Things like non-steroidal anti-inflammatories could kind of be your death knell if you got COVID-19, and everyone was getting very concerned. People kind of constantly looking at their phones, news feeds. There was misinformation going around. This is kind of my memories of it, and there is a definitely increased stress for frontline professionals, and this is widely recognized, particularly in very areas with high prevalence such as Italy and New York. So then a lockdown was imposed. My own experience was this resulted in reduced presentations of patients to the clinics, probably to the hospitals as well. And we were really kind of only seeing really severe emergencies was what I was saying. I think people were afraid to come to clinical settings, and this was probably reducing the footfall. And then a huge effort at this time was dedicated to kind of planning strategies to cope with the many implications of COVID-19. In particular, I think a big early issue was on psychiatric wards. Like we were all very fearful that we'd get an outbreak on a psychiatric ward where there's vulnerable and elderly populations. Obviously there's been some very sad outbreaks in many institutions around Ireland. Also managing acute presentations while trying to implement social distancing has been extremely difficult. Maintaining staff morale has been difficult at times, particularly frontline workers, nurses, doctors, and other professionals has been a challenge. And I think as the lockdown eased, presentations increased to psychiatric services. In our own service, we've definitely been busier the last few months. And I think there is some data to suggest that footfall did increase over, once the lockdowns were eased. But there's still concern about less face-to-face contact. Is there people out there that aren't presenting, concerned about COVID-19? And this is a kind of an ongoing concern. So, there's been some studies about how COVID has affected mental health. Current research is preliminary, kind of based on surveys, a lot of it. There's some evidence of increased anxiety and depression. Not fully clear about effects on things like self-harm, psychosis. It's not fully clear, and we might need to look backwards to in months and years to come to see the full effect on mental health of the population. There's been other effects discussed, like online gambling may have increased. I know Professor O'Gara is on the line. He might be able to comment on that. It's uncertain whether there's been increased alcohol use. There has been kind of increased sales. Binge watching television, which can impact on our mental health or energy levels, fatigue. That's also probably increased. And among those who have gotten COVID-19, there can be direct effects such as delirium, which is very prominent in ICUs, and post-viral depression, post-viral fatigue, this executive syndrome. This kind of like a ME type syndrome seems to be happening in some people with COVID-19. Okay, and then so why has COVID-19 affected mental health? And I mean, I suppose there's some things it could be related to the virus. Also lockdowns. This is another kind of a unique, it's a parallel issue essentially to COVID-19 pandemic. But in and of itself, the lockdowns are possibly affecting people in a big way. And there isn't one reason. I think and every mental health presentation is very complex. Certainly things like isolation, change relationship dynamics during lockdowns when people are forced to get away from their routine and be around their families too much. Perhaps it might not be helpful for everyone. There's been reports of increased domestic abuse, possibly alcohol use, employment and financial effects. We probably haven't felt the full brunt of that yet. Then anxiety about getting COVID-19, and as I mentioned, the direct effects of the actual illness. Also, grief has been a really sad and tragic part of this pandemic, with limited numbers in being allowed into funerals, families not being able to spend the last moments with somebody who might be dying from COVID-19. These are all horrific situations. Okay, so I'll just briefly mention a few things. So the mental health of frontline health workers has been a major topic of discussion from early on in the pandemic, and it became evident, particularly when people were managing hugely increased workloads in emergency departments, ICUs, frontline staff, that this was possibly affecting their mental health. Managing complex situations on a daily basis while wearing PPE. This was all, very challenging situation, and important to acknowledge that there's many members of society that could be affected by this, and such as police workers being spat on and coughed on, when they're trying to exercise their duties. And essentially, there's been lots of populations vulnerable to mental illness. Clearly, the elderly. Due to isolation and grief, people with intellectual disabilities whose routines were affected. Vulnerable groups such as the homeless population have been spoken about, and the youth population who've had to have huge changes in their social interactions, closure of schools, universities. So there's been a large portion of the population affected. Without being too doom and gloomy, there might be some positive benefits as well. It's always good to focus on cling on to some positives. I mean, the lockdown did force a break from work for some people who may have been burnt out or overly stressed, forcing them to spend more time with their families, offering them perspective on their lives and values. There's a great community spirit, I think, for helping and supporting the elderly populations. Which was great to see, and I think this has helped people, the people helping the vulnerable populations, just improving social cohesion and community spirit. We also have increased awareness of mental health issues in society. People working towards a common goal may have experienced collegiality, and experienced healthcare staff have returned to work from retirement. And there's been some innovation in mental health services. So I think in any crisis, we can always learn. And hopefully use that as a platform to help our mental health, rather than just focusing on the negatives. So I realize we don't have much time, so I think it's just important that we kind of continue to work together, work flexibly, continue to raise awareness, to support vulnerable groups, provide advice for the general population. And I think in the future, there's still a lot of uncertainties. It's important, I think, that we kind of cling on to the potential positives. We kind of stick together, helping each other, and our communities. It's unclear how long until we have a vaccine. The post-viral effects of the illness are still not fully clear. And the economic impact of this may unfortunately linger for some time. So that's a kind of a summary of kind of some of the submissions we had to the journal, and some of my perspectives as a general adult psychiatrist. So how we're going to run this session now, I'll pass you on to the next speaker, who'd be Jane McGrath, Professor Jane McGrath, who submitted a very interesting paper on her specialist service on ADHD to the journal. I'd be very interested to hear her own perspectives on the lockdown times, and we'll have a discussion maybe at the end. Hopefully we'll have time for a discussion at the end. So thank you.
Great. Thanks, John, and thanks to Fiona and Bláthnaid as well for the invitation to talk about the article that I wrote on ADHD and COVID-19. So in the 5 minutes, it's not a long time, and there's so much that I could say, and I want to answer John's comments and his really interesting overview and the talk that we've just heard a few minutes ago in the previous seminar. But I'll focus for the next 4.5 minutes on COVID-19 and the impact that it had on service provision in Admire. Admire is the specialist ADHD service that I lead in Lindera Child and Adolescent Mental Health Services in West Dublin. And I'll comment on two particular aspects: physical monitoring and telepsychiatry, and then just come 7 months on and look and see where we're at now. So Admire was set up back in late 2018, and the role of the service is really to offer early access to ADHD assessment and diagnosis, initiation of treatment and research, and we do lots and lots of education for children and adolescents with ADHD. We've a rolling caseload of about 240 children. So the main difficulties that we faced in March and April 2020, when the government restrictions came into force, was that there was very significant reduction of face-to-face consultations. And that led to a number of difficulties. So there was postponement of new assessments and difficulties with physical monitoring because the children and adolescents weren't coming into the clinic. And there were delays then in medication and starting medication and in titrating up medication because we weren't able to adequately monitor them from a physical perspective. Other issues included lack of group interventions, and there was huge problems with access to controlled drug prescriptions for all children who are on GMS scripts. So with physical monitoring, in April there was 210 patients and 33 were under assessment. 177 were on medication, and of that group 151 were on stimulants. So NICE guidance from the UK, they're very clear about the cardiovascular monitoring requirements, pre-medication, stimulant medication, and during titration of medication. So as this specialist service, we had so many children on stimulant medication, we really felt there was an urgent need to provide adequate physical monitoring during the pandemic. And I went to a number of different talks and read various different things. And there was a very helpful paper published by the European ADHD Guidelines Group in The Lancet in April 2020. And they strongly advised continuing ADHD assessment and starting stimulant medication when indicated. But they suggested that the physical monitoring would be carried out by GPs or maybe by pharmacies or home blood pressure monitoring. And the problems for our service was that really GPs weren't seeing these patients and they weren't seeing anybody face to face. Pharmacies wouldn't allow children to cross their thresholds, and most families had no home blood pressure monitors, and a lot of them couldn't afford them anyway. So we developed a dedicated physical monitoring clinic. So there was just very brief face-to-face physical review for these children. And PPE was in really short supply at the start. It was very, very stressful, but it was reserved for the clinic. We did COVID screening and copious amounts of cleaning, and that clinic is still running and has been really, really useful for us. The second aspect I wanted to talk about was telepsychiatry and ADHD. So a systematic review in April 2020, there was lots of prolific writing in April 2020, but suggested ADHD is a disorder that's well suited to a telepsychiatry approach. And so we thought, okay, well, we can't see these children, will we try video conferencing? The American Psychiatric Association and American Telemedicine Association have published best practice guidelines. So we had to look through those and we thought, oh yeah, okay, the security of the platform, the quality of the signal, I'm sure we can manage all of this. But our reality was quite different at the start. This wasn't expected. Things were not set up for this kind of a service. And there was a lack of access to computers with cameras and microphones for many staff. There was lots of difficulties with platforms, and people in Lindera camps put in a huge amount of work to try and get things up and running for staff. We weren't allowed to use Zoom because it wasn't secure. Skype didn't work downstairs in the part of the building we were in. WebEx worked for people if they had a laptop, but you had to send them your personal email address in the invitation, so that wasn't always ideal. Attend Anywhere has worked really well over the last 4 to 6 weeks, where you can text or email an invitation, and people have been able to use that quite well, and it's working for us. But service users have had difficulties too. A lot of them don't have access to a computer or a tablet. Some don't have access to smartphones. Lots of them are saying it's too expensive with their data subscription, and some families just don't want video calls, probably for privacy reasons. So where are we at 7 months on? So a lot of the difficulties that we had in March have largely resolved. So many face-to-face consultations are being done. They're reduced but available when necessary, and we've lots of PPE now. So new assessments are continuing, using a mix really of video conferencing for the longer history taking and then face-to-face assessment for the reviews of the young person. The physical monitoring clinic is well established, and medications being started when indicated and titrated for everybody. But the problem is that new difficulties have emerged, and I'm sure that these are probably common to everybody. And I don't know that I really anticipated this properly, but there's huge absences of staff for up to 14 days. Very unpredictable attendance of patients due to COVID or testing or isolation, if they're a contact, etc. Time difficulties as well. So time to do COVID screening, time to put PPE on and off, constant cleaning, set up of video calls, etc. And the lack of group interventions has been a real problem for us as well. So we normally run a parent program, which is very valued by the service users. And we've set up a website with different for psychoeducation, but it's in no way going to substitute the parent program, because families learn so much from the interactions that they have with each other. So finally, I'd just really like to acknowledge the team. It's been really hard over the last 7 months. People have really pulled together and put in a huge amount of effort. And thanks to the overall Lindera group as well for I suppose allowing us to pull everything together. I apologise that I have to leave this meeting a little bit early today, so I won't be around for the session, the discussion at the end, because I had another meeting I couldn't get out of. But if anyone has any questions or comments that they want to address to me, my email's on the slide here, and please feel free to get in touch. I'd be delighted. Thank you.
That's great. Thank you. Thanks, Jane. Thanks. That was a lovely run through. Yeah, it'll be interesting to kind of compare the services and see if people are experiencing the same types of issues. I suspect they might be. So we'll move on now to our next speaker is Professor Colin O'Gara from St. John of God Hospital. And he's an expert in addictions. And he's submitted a very nice perspective from that to the journal. So Professor O'Gara, if you want to take it away.
Am I unmuted is the question.
Yes, you are.
You can hear me. Brilliant. We're 99% of the way there now. Getting over that. I've had some interesting experiences with that to date. Thanks very much for the invitation to speak, and great to see all familiar faces there. So our paper was on addiction, and I don't think there's going to be any talk this afternoon that doesn't focus on stress. I mean, stress was huge. John, you alluded to it. And we saw definitely an increase in admissions as a result of stress That was feeding down into the various addictions. I'm afraid I don't have any high quality evidence-based medicine in that regard. It's just going to have to be purely anecdote. But I think over time studies will feed through, and you know, what they will be focusing on is the fact that there was significant isolation, boredom, lack of distraction, and critically no AA meetings at all whatsoever on. So all of that came together in one go. Also from the point of view of cocaine, there was significant pre-COVID issues with cocaine, and we saw throughout the pandemic that continued, and it's continuing at the moment. There was a focus on the cardiovascular effects of cocaine and would that lead people to be more prone. Similarly with opioids, fracturing the supply of opioids would lead to a drop in tolerance in people who couldn't access opioids, and that then might lead to significant problems for that group. So you mentioned gambling, online gambling. We're a very, very interesting situation with gambling, where all sports betting basically disappeared off the face of the earth. And we had, in our more severe cases, we had people going on to online slots and looking at virtual gambling. Now, a lot of people would know what virtual gambling is, but the bookies didn't waste any time in introducing everybody to that concept. Because they did, if you can remember, a virtual Grand National, which was a very sophisticated way you know, of getting a load of people into virtuals who'd never gambled in that way before. So we wrote to the bookmakers in that regard, asked them if they could limit the amount of losses that people would suffer over the pandemic. And just prior to COVID as well, there's a credit card ban in the UK. And unfortunately, that didn't come in Ireland at all. So again, a bit of a perfect storm where, you know, loads of people could gamble more and lose a lot more money. Certain countries took the lead. For instance, in Latvia, they put a full ban on online gambling. So on the ground, just a few quick points. We were an inpatient service, so we had to immediately look at social distancing from a group therapy point of view. Group therapy is a mainstay of what we do. That was getting out the measuring tape, measuring 2 meters, and over time, we've had to reduce group sizes, bring in additional groups, bring in additional staff. Try to move people away from the concept of COVID obsession and try and focus on the fact that they're coming into the inpatient setting to do work on addiction. We were super lucky in that we had single rooms. John O'God's has got single rooms, and we realized quickly that if people had symptoms, you could isolate them in single rooms. Similar units that were dormitory based were in big trouble. They practically had to shut down. Temperature checks, masks, hand washing. We've all, you know, we've heard that ad nauseum, and that is effectively what we're doing in the early days. But leave as well. Weekend leave was an integral part of our program. Getting people out of the hospital, getting them used to the environment before they go home. They couldn't do that, so we had to renege on one of our other key features, which is not allowing people to have mobile phones, because there's so many addictions that are based on the mobile phone. So we had to give the mobile phone back to people and allow them to have the phone 6:30 to 8:30 every evening, and then all day Saturday, all day Sunday. So meeting people in the middle somewhere. Like with John at the end of your talk, you know, there's certainly positives. For well over 10 years here, we're sending people to accident and emergency departments and medical departments to get IV Pabernex. Within the course of a few days, that suddenly changed. We decided that had to happen on site. So that's a real positive. So any of the resistance to that, for whatever reason, went out the window, and it happened. The other thing is that some of our medications, such as thiamine and multivitamins in the treatment of alcohol dependence, you can give to people. So we've introduced this idea of self-dispensing on some medications, which have avoided contact, and it's also avoided a stigmatizing part of, you know, people feel queuing up for their medications is quite stigmatizing in the inpatient setting. So it was goodbye partly to that. Jane was mentioned telepsychiatry. I mean, I have to laugh somewhat at that. I mean, we hummed and hawed for years with telepsychiatry, myself included, and within 2 or 3 weeks, we were all sold, entirely sold, and right in there big time. And just last point, you know, for many of my patients at the moment, you know, the team, other team members that work with patients, this is a unique opportunity for people specifically in addiction, because there's no pubs, there's no nightclubs, a lot of social contact is shut down. So we really are, for a lot of people, this is a unique opportunity, and there isn't a day that goes by that we don't highlight that with people, and hopefully they can use it. So I've no idea how long that took, but hopefully it's about 5 minutes.
Lovely. Perfect.
Thank you.
Yeah, thanks very much. Thanks, Colin. That was excellent. A lovely rundown, and I think you touched on a lot of important points. So we'll move on to Dr. Brian Hallahan, who works in the Galway services. He submitted an interesting paper about anxiety disorders. So real data on people with anxiety disorders during COVID. So this should be quite interesting.
Thanks, John. I don't know, can everyone hear me? I'm just trying to get. Yeah, I'm just going to put my slides on. I've only 4 slides. You'll be happy to hear, so it won't take too long. This is a paper on patients who have pre-existing anxiety disorders. I suppose there's a lot of data and perspective pieces and some excellent pieces on, I suppose, the concerns people have that there will be major mental health difficulties, and you hear terms like tsunami mental health issues. And we want to see what's having an effect on people with established mental health disorders. And we've done a number of studies actually, but this one was on people with anxiety disorders, and I will share some of the other findings as well, if that's okay. So we wanted to examine not just the psychological or psychiatric impact, but also the social impact of COVID-19 and the mandated restrictions because of that on people. And we looked at sort of 2 groups. Now, our numbers aren't great, but on those with what we suggest would be trigger disorders, so things like obsessive compulsive disorder, social phobia, agoraphobia, and those more free-floating anxiety, like generalized anxiety disorder, panic disorder, mixed anxiety and depression. This is approximately 6 weeks into lockdown, so people were, I suppose, getting used to the restrictions and potentially struggling with them. So we looked at a range of Likert scales for anxiety symptoms, mood symptoms, social functioning, occupational functioning, quality of life. We looked at the effect of the restrictions on their mental health, so, and anxiety symptoms, and basically did they feel that they were better, the same, or worse? And we utilized some very standard psychometric instruments and attained some data on demographic data, so employment and vocational data as well. So 30 patients responded, so I think we'd 55 or 6 that we invited, and just a slightly higher portion were female, and 17 had either obsessive compulsive disorder or a phobic disorder, actually 12 of those CDs. So again, not large numbers. I suppose interestingly, all those that were employed ended up having either their jobs terminated or moving from their place of employment to their own residence. And this wouldn't be, I suppose, out of keeping what happens nationally, but no one stayed at their site of work. We found no difference really between those who had different types of anxiety disorders, but potentially, I suppose, those with those free-floating disorders had, I suppose, more anxiety symptoms, but not statistically so. The greatest impairment was in social function, followed by quality of life. When we score people out of 10, they would describe that these areas were most significant, whereas things like anxiety, mood, were less impaired. Some people, we looked at the clinician's view, so their clinical global impression compared to the last time they were seen, so the improvement. We also looked at patients' own perspectives. So look at their own perspectives. Half said it had an adverse effect on their mental health. One quarter said it had a good impact. Another quarter said no change. But the clinicians felt that, you know, more people actually improved than disimproved over time. And 47% had improved and 27% had disimproved, and the rest were unchanged. Now, the improvement has been quite moderate or minimal, but still there was some improvement. If you had a comorbid mental health disorder, some may have had same, or a physical health disorder, it didn't impact on patients. So COVID-19 had some impact. This is predominantly on the social functioning and the quality of life, but a relatively minor, but not nil, impact in relation to anxiety symptoms. And of course, there's some individual variability on that. So why do people do relatively well? I suppose some people receive some ongoing support. I think Jane mentioned about initially there were people off work and it was difficult, and that's changed now. But I think by the time it came to the study, our team is working, keeping in contact with people. Sometimes it was on the phone or using other telecommunications. Sometimes it was in person. Some people probably benefit from social restrictions. Those is the social anxiety disorder, for example. This group weren't heavy users of alcohol. Some drank alcohol, but we didn't have anyone that was dependent on alcohol. There was no significant psychoactive substance use. I suppose people are resilient. Lots of people do well and have very good coping mechanisms. So many said to me, well, look, I have an anxiety disorder, and whilst COVID is a worry, I've overcome greater challenges. Currently, we're doing a follow-up at this stage now, so many months later, to see if this changes, because that was early on, but people may be getting tired and fatigued of, I suppose, the restrictions, particularly now as we're in level 5. So we've re-recruited most of these people in the last week to ascertain how they're doing now. We're also looking at other cohorts of patients, and I think just maybe away from away from the study itself, what I think we're finding are those patients with bipolar disorder, schizophrenia. We got a lot of data on this that will be hopefully some into this in other journals in the near future. They seem to be doing relatively well. Patients with emotion stable personality disorder, we see are struggling, and they seem to be struggling more than other patients. Looking down compared to bipolar disorder, they seem to be struggling more and more significant symptomatology, but particularly in relation to social functioning, quality of life, they seem to be struggling. Patients with schizophrenia, many say it's not having a significant impact, but of course there's individual variability in the lack of day centers and other groups. So I suppose the message from me is that some patients are often very resilient. I think there's a lot of distress in the general community and general population in relation to COVID-19. Of course, it affects all people and people with mental health disorders as well, but many have managed very well. And many have done very well, and our findings in this and a couple of other studies are demonstrating that in our patient cohort, the social impairment is significant, but they're doing a lot better than I thought they would be. So thank you very much.
Fantastic. Thanks very much, Brian. That was very insightful, very interesting as well, that see some people are doing well, and I think the long-term follow-up now will be very interesting. And I did notice that as well. Definitely some people were quite resilient, and they were maybe even their mental health was as good as it had ever been early on in the pandemic. So other people definitely were affected negatively. So it'll be very interesting now that longitudinal follow-up. Okay, we'll move on to our next speaker, Professor Brendan Kelly. So we're delighted to have Professor Kelly to present today about, he submitted a paper about plagues and pandemics and the history of this in Ireland and mental health effects of it. He may have some other insights to talk about, but I'll let Brendan take the stage.
Great. Thank you very much, John. Can you hear me okay? Am I doing okay? Perfect. Technically? Brilliant. That's great. Look, thanks for asking me along here, and thanks indeed to Fiona and Bláthnaid in a more sort of sustained way for all the Friday lunchtime seminars. And thanks, John, and you again for this. It's been very helpful to have these, to go along as the situation moves on. And I thought the Irish Journal of Psychological Medicine special issue was very useful, as indeed was an editorial in the Irish Medical Journal by Bláthnaid and Fiona and colleagues. The paper I wrote was about history, and the great thing about history is no matter what happens today, when you look it up, you find that it happened before in one form or other. At the time, everybody thought it was new and unique, but it wasn't then, and it isn't now either. So I suppose the two big comparators here for us are the influenza pandemic, 1918 to 1919, and maybe also tuberculosis in the asylums in the first half of the 1900s has something to teach us as well. But what really struck me was this quote from 1856 from the census. And the census back then was often a sprawling literary endeavor, volumes and volumes of reflections by the people who wrote it. And Sir William Wilde in 1856 wrote about plagues and pandemics in Ireland. And here's what he wrote. This is 1856 now. Many of the plagues from which this country has suffered were continuations of waves of pestilence, which had already passed from the east and over the European continent, carried along the track of human intercourse. And it's interesting when you see COVID-19 apparently coming from China originally and following the path of human intercourse, you know, literally following flight paths out of China and then across the world. But the first real comparator, I guess, is influenza. We'll skip over the bubonic plague, which in the 1300s, there was wave after wave of it, separated by many years, going on for many years, and it wiped out about a quarter or a third of the entire population. Now, for the purpose of everybody's mental health, I will skip over that, and we will only compare the present situation with the influenza in 1918. And the influenza, the Spanish flu, was interestingly different to our current pandemic. It was probably less infectious, and it affected the population in a way that has never been fully explained. Younger people got a worse illness and were more likely to die. Older adults were largely spared with the Spanish flu. So we've probably roughly looking at the opposite distribution at the moment. So it's a different entity. As you might know, there were 3 waves of the Spanish flu, starting with the first and smallest wave, early summer 1918, and it had largely cleared up by July. It wasn't quite gone, but then there was a resurgence, and you could call it a second wave. I think we're calling it a resurgence now, but whatever, which began as the autumn came, but that ended pretty much by the end of November. And then there was a smaller third wave in spring 1919, and that was a small wave, and it was the second wave that was easily the largest and the most deadly. How did it come to an end? It mostly came to an end on its own, as far as we can figure out. Treatments were poor, public health measures were brought in and variously observed. So I suppose some public health measures in the passage of time, and then changes in the virus itself. Now the asylums, because that's really the only measure we have for how this affected people with mental illness at the time, the asylums were badly hit, but not necessarily because of anything to do with mental illness, because they were so big and overcrowded and unhygienic was the problem, constantly having waves of infectious and infective illnesses. So even prior to the Spanish flu, around 12% of asylum patients died every year in the asylums, mainly because of poor hygiene and infectious illnesses. So it's no surprise at all that when the Spanish flu came along, in Ireland as a whole, 800,000 people were infected and around 20,000 died. And in the asylums, around 1/5 of patients were infected and about 1 patient in every 7 in the asylums died. And it hit particularly hard in Kilkenny, Castlebar, Maryborough, interestingly, in Portlaoise, and Armagh. So, for the population, the influenza was far more widespread than COVID is, and the deaths were 20,000 over the course of the whole thing, maybe higher. And I think with COVID, where are we with deaths in Ireland? Are we at 1,500? I stand open to correction there. But the Spanish flu then went away. But I think a really interesting comparator is tuberculosis as well. And we know from Ireland's history, the mental health services, tuberculosis remained a huge problem in asylums for many, many years. And as they rebuilt and extended asylums in the 1920s, 1930s, they built entire tuberculosis wings and tuberculosis buildings. And tuberculosis was only eventually controlled when there was effective treatment, plus effective vaccine, plus effective public health measures, and even then, it hasn't gone away fully. You know, it's still around a bit. And while the organisms are different, COVID versus the influenza of 1918 and versus tuberculosis, obviously, the big question is, which pattern are we going to look at? I don't think it will be as crisp as the influenza, 1918, 1919, but neither is it likely to be as protracted as the tuberculosis. In terms of the mental health history, I suppose, the effects of these on mental health are difficult enough to figure out. We know people with influenza, say an older adult with a bad dose of influenza, there's a 40 to 50% chance of them developing a depressive illness within the next 6 or 12 months. Some of that might have occurred anyway, but it greatly increases the risk even nowadays. So I think other people here are better qualified than I to talk about the longer term effects of COVID. But I think we're likely to see something similar as we see with influenza still, let alone back in 1918. And hopefully we won't have the embedded institutional problems that we saw with tuberculosis. I suppose the key thing is, looking at the history of these in the mental health service, is we're better off now that we have a more community-oriented service. And I think Brian Hallen's and his colleagues' study was really interesting about that, because it was such early numbers, and it showed that some people, if I'm correct, Brian, who are already attending, their mental health didn't appear to suffer that badly, some of them, but they did appear to be attending maybe that little bit more, or accessing support that little bit more once it was there. And I think we're in a much better position as sort of a mental health system now that we're more community and less institutionally oriented. But anyway, I bang on about this at length in the paper, and I bang on about this at length all over the place. So I won't bang on about this any longer here. Thanks for the 5 minutes, John.
Yes, yeah. Thank you. That's fantastic. That was really insightful, very unique perspective again, and I think we can learn lots from looking at all the various angles on this. So thank you very much. Next up is Professor Paul Fearon, Clinical Director in St. Patrick's University Hospital, who submitted a paper about their experience in St. Patrick's Hospital. It'll be very interesting to hear your insights today. Paul, if you want to take it away. Mm-hmm.
Sure, thanks very much, John. And I'd like to echo Brendan's comments to yourself, Fiona, and Bláthnaid, particularly for the fabulous edition of the journal. It's a really important document. So in my 5 minutes, you'll be glad to hear I'm not going to go through every single bit of the paper. I was approached to write it, and I thought it was a really good opportunity to actually document what we've been doing over the previous 6 weeks or so, because as everybody knows who's listening in, things were so busy and we were having to react so quickly to things that to actually have the luxury of being able to stop and sit down and process it. What I'm going to do over the next 4.5 minutes or so is just maybe pick out 3 things that we might have done that might be a bit unusual, and also maybe 4 messages that really I feel need to be learned, particularly by ourselves, and that we are learning. A little bit of background: we're in the independent sector. We receive no government funding. It's mainly from insurance, health insurance companies. We have 300 inpatient beds, 50 of which are in St. Edmundsbury and Lucan, about 20 minutes up the road, and the remainder in St. Patrick's, our central campus, of which 14 are adolescent unit beds. We see about 1,000 new referrals a year as outpatients, and about 15,000 review appointments. So we have about 8% of the adult inpatient beds nationally. Being in the independent sector initially felt like it was a disadvantage when things were beginning to happen, because we were kind of, if you like, potentially a little bit out of the loop, but actually it turned out to be an advantage in the early stages, partly because we knew we needed to be self-reliant, and we also knew we couldn't afford to hang around and wait to see what happened. Also, we were able to make our own decisions on how we wanted to proceed, while at the same time absolutely adhering to all HSC and government guidelines in terms of how to deal with the pandemic. So we very quickly, I mean, there are 2 things about the initial stages. First of all, it was, I think, very possible to predict in advance of the virus hitting Ireland what was likely to happen. We knew that it had already, by early February, had hit China and Italy. We knew what was going on there. The only questions really were, is it likely to come to Ireland, yes or no? Is there likely to be a vaccine, yes or no? And if not, what are the likely things that people are going to need to do in order to try and mitigate the arrival of the virus in Ireland? And once you had those broad piece of information to hand, then you just needed to really decide what your purpose is as an organization. For us, we decided very quickly it was, first of all, to keep our staff and our patients and staff safe to the best of our ability. And second, we wanted to treat as many people as possible despite the pandemic. We didn't, hence the title of our paper, Opening Up While Locking Down. We were really determined to treat people, at least as many people as we would under normal circumstances. So the only question was how we would do that. So three things I'm going to talk about in terms of what we were able to do. First of all, we had two natural advantages. We were just very lucky. First of all, we had a separate site. We had St. Edmundsbury in Lucan, a 50-bedded hospital with all of which were individual rooms. Under normal circumstances, they would be general adult psychiatry patients, 3 teams, consultant teams working there. We decided fairly early on, after our first of 3 cases in total during the pandemic, given the potential fallout of a case, particularly in terms of staff having to self-isolate and patients, that we would turn St. Edmundsbury into our isolation unit, essentially. So we basically, anybody who needs to self-isolate, either confirmed, suspected or symptomatic, we would bring out to St. Edmundsbury while they waited the result of their test or for whatever reason. And when they were able to return to St. Patrick's, to the main campus, they would, which meant that we were able to pretty much guarantee that St. Patrick's at all times would remain pretty much COVID-free. The other advantage we had, which again was entirely fortuitous, was that about 3 years ago, we set up an electronic health record. And I can't tell you how useful that's been, because with the addition of telepsychiatry, which we embraced, and an electronic health record on everybody's laptops, staff who had to self-isolate at home or whatever were able to continue their clinical duties. But the other thing we were very cognizant of, particularly in the early stages of the initial lockdown, whether people might be either afraid to come into hospital or unable to come into hospital for whatever reason. So we negotiated with the health insurers. We said, listen, there's going to be a whole tranche of people who need mental health treatment, who may not be able to access treatment or even a referral, but whom we need to treat. So we proposed to them a home care service, wherein clinically suitable patients who might normally come in as inpatients, that we would provide everything except a physical assessment as a remote patient using remote technology. That would be ward rounds, MDT meetings, psychological assessments and treatment, groups, activities, prescribing, the works. So for example, with prescribing, we would fax the prescription to their local pharmacy, their nominated pharmacy, for them or a member of the family to collect. At the height of the pandemic, we had about 120 people we were treating remotely. We would also reserve a physical bed for them, so that if they needed to come into hospital for whatever reason, there was a bed nominated for them. They also knew basically what ward they were allocated to. That combined with the St. Ed's situation, where we had maybe anywhere from 0 or 1 to 7 or 8 people self-isolating. The remainder of those beds we were able to allocate as virtual beds for home care patients. Currently, as I speak, I think we have 70 patients still on home care. And surprisingly, because this was rushed, there's no evidence base for it, but the feedback has been very positive and people are very satisfied with it. Initially, we thought it might just be that people were thankful to have it at all. But in fact, as things have gone on, it has certain advantages, particularly in the adolescent service. I won't go into that in detail. If I had 4 piece learning things from this pandemic and how we've been responding to it, it's number 1 is be clear on what your aims are, and be clear on that it's possible to predict things. And the prediction may seem outlandish, but it's you know, these are outlandish times, and act on them. I think I can't think of any situation where inaction during this pandemic has been better than action. Usually actions lead to better outcomes than lack of action. And allied to that is the speed of action. Don't delay, don't dilly-dally, don't wait for to see what other people are doing. Don't wait to be told what to do. We need to actually decide, once we've decided what we want to do, how do we do it, and just get on and do it. We need to stay ahead of things by even a couple of days is crucial. I remember when we decided to really limit visiting, there was a lot of discussion about, are we being too draconian or whatever? And as we were introducing 1 visitor per week, the Taoiseach made his first announcement on national television, etc., about the lockdown. And suddenly what seemed controversial 2 hours previously suddenly was perfectly normal. We need to constantly evaluate and adapt what we're doing. I remember a few months ago, it's not even a few months ago really, but everybody will remember Major Dublin Hospital was chastised for introducing mandatory mask wearing among staff, you know, and that seemed ludicrous now. That was only a few weeks ago really. So things change very quickly and we need to adapt with them, constantly evaluate. And finally, arguably most importantly, we need to communicate both to our own staff and to our service users and patients. I think this is key to things both nationally and within services. We wouldn't have been able to do what we've been able to do in St. Patrick's without buy-in from staff and from our patients. And a lot of that buy-in came from being very transparent about why we were doing what we were doing, the rationale for it, and what we hoped to achieve. And we were therefore able to do it. I think the next few months are going to be testing. Testing is a bad word, I suppose, in the current circumstances, because I think testing is going to be very stretched. But I think we need to really keep on our toes. Thanks very much.
That's great. Thank you very much. Thanks, Professor. That was fantastic. Great to get your perspective there and some really good kind of tips at the end as well. And I think it's important that we do all communicate closely. Remember as well, in workplaces, we are all kind of, we do need kind of human contact because, you know, we all work in challenging and stressful environments. So that communication piece is important to be aware of that, not to let it go. So yeah, thank you very much. Okay, so we'll move on then. Next up is Dr. Pat Devitt, who's submitted a paper focusing on suicide and previous major events. So this is a very interesting topic again. We've had some great speakers today. There's two more just to let you know. I know we might go a few minutes over, and I hope people are interested enough to stay on. So Pat's going to talk about major events and suicide. So take it away, Pat.
Thanks very much, John. I'm just setting my timer there. The topic that the title was, can we expect an increased suicide rate due to COVID-19? But the everyday, the lay purveyors of doom and gloom were, as Brian referred to earlier, predicting a tsunami of mental illnesses. And if you extrapolate from that, there would be a tsunami of suicides as well. And suicide is a very big topic in the media in general. In fact, just on a walk there recently, I saw a poster on a lamppost from Pieta House, inviting people to come and seek their services. So it's something that is in the news, and even if Ireland lose a football game, the predictors are that the suicide rate will go up if we lose against Slovakia or whoever. So it's an important topic, but a caveat first, it's very hard to predict it. And so in order to have some stab at it, I looked at the past. I wasn't sure whether to equate it to a war, a natural disaster, an epidemic, which it is a pandemic, of course, and how it compared to that, or an economic recession or a depression. So I looked at most of them. The war thing came from Durkheim in the 19th century, actually. Or no, sorry, what century was he in? It was 1890. That was the 19th century, and he predicted that in wartime suicide rates went down because of increased social solidarity. I looked at further studies which more or less seem to debunk that. In fact, the suicide rate actually went up in Scotland among young men. It didn't follow the trend. So there was no great. If there was a sense of social solidarity, there was no great evidence that might lower the suicide rate. And then natural disasters, they're difficult enough and there wasn't a huge amount of information on them, and they followed up sort of short-term rates for the following 6 or 12 months or 2 years. And there were spikes in increases in the suicide rate, but nothing that was actually lasting. So again, that wasn't really that helpful. In terms of epidemics, I nearly said academics because Brendan Kelly was talking about the Spanish flu. So there was no great evidence either about suicide. There was some evidence, a very good study that compared the Spanish flu, World War I, and Prohibition in the States. And the conclusion was that the Spanish flu may have caused an increase in suicide rate. The war caused what was equivocal, and alcohol, the reduction in alcohol actually caused a reduction in suicide. So moving on to SARS-1, which I thought was probably the most relevant, even though it wasn't a pandemic, but it did affect the Hong Kong and the Asian countries quite significantly. And there was a definite increase in suicides among the elderly, who were probably most affected, similar to our current SARS. and also were isolated, and so there was an increase for them. But also more interestingly was when another study looked at the reasons why people might feel suicidal in that age group, where they felt like they were a burden. Now it's very interesting too that in the early days in the United States and in Britain, there was a lot of talk of more or less they're only nursing home patients. They're the elderly and they're sort of dispensable or disposable. That was an idea that was coming across. And you can see how that would affect the elderly. And even on the radio today, the elderly are affected. And the fact that they were taking to heart what were only guidelines really, and they felt they had to stay in. I suppose they're more rule observing than the young by definition. So overall, extrapolating all of that, and of course the biggest one, the lot, is the economic factors. And it's well known in the Big Depression, 1928-29, that there was a huge increase in suicide. We all know these pictures of stockbrokers jumping out the window, and also our own recession. There was a very good Irish study that showed that if you look back over blocks of 5 years, there was a definite increase. And again, among males and young males and previously successful young males were the people whose suicide rate increased. So what is our current pandemic? Is it a bird or a man? Is it a disaster, a war type? So there is a sense of solidarity among the population, at least during lockdown 1 there was. I don't think there's the same sense of solidarity now, so that could be protective actually. But in fact, there is going to, the recession probably hasn't hit because of the mitigating measures that the government have put in place. And there has been previous studies showing that where mitigation has been put in place, suicide rates are much better in terms of the Scandinavian countries as opposed to other countries who are more laissez-faire. So in terms of the economic recession that may come in the future, we probably can expect some increase relative to that. Taking the lessons from SARS-1, we would expect that the elderly group would be even more vulnerable because it's their colleagues who are dying and they're afraid of dying. And then also there are some specific groups that are probably more affected than most. And we saw the nursing home in Galway, Haskra there on the news last night, where the owner of the nursing home was crying. So, I mean, so it is very tough on people running nursing homes, trying to work there without staff. Even Killian the Gascoon is without staff this weekend. So it's tough on healthcare workers. They're working long hours. They're having to make these sort of moral choices, moral dilemmas, and so on. So my conclusion really is that we don't know if the suicide rate is going to go up. But if the rate of mental illness goes up, you probably can assume there will be some increase in suicide. That is a factor, but not the only one in suicide. Social factors are very important, and this certainly has had a huge social impact. So I'll leave it at that. Thanks. I went over 1 minute over.
5 minutes and 2 seconds, I think. Fantastic. Well done, Patrick. That was very interesting. Again, very insightful. Always lovely looking back over the history and how this can impact us. Because often that's all we have. We can't look back over this time with a close eye until afterwards, perhaps. So thank you very much. So our final speaker today is Dr. Karen O'Connor, who works in the Cork sector. And she's going to talk about a national committee she was on that looked at the impact of COVID-19 on secondary care mental health services. So without further ado, take it away, Karen.
Thanks, John. Thanks very much. Thanks, everybody. And thanks for everyone staying on to hear the last speaker. Thank you. So I'm Karen O'Connor. I'm a consultant psychiatrist, and I'm the national lead for the Early Intervention and Psychosis Programme. And it was a group of us really in the clinical leads office in National HSC that got together to write this. I suppose the context was that a group of us, we work with Dr. Amira Niazi, who's the National Clinical Advisor and Group Lead in Mental Health. We were very concerned about the potential impact of the pandemic and the restrictions on mental health, and specifically on people with, I suppose, severe and enduring mental illnesses and secondary care mental health services. If you can bring yourself back to kind of April, May, there was a lot of talk, there was quite a bit of talk about mental health and the impact on mental health, but there was also a lot of talk about, you know, move online, self-care, and all of the things are really, really important, really helpful. But they're not going to solve the challenges for everybody. And we felt it was important that we, I suppose, recognize the impact of the previous recession and the fact that that was not associated with any kind of investment in mental health services, or certainly no increased investment. And we tried to advocate for secondary care services. So what I'm going to briefly cover today is just, the first thing is this graph. And I won't labor this because you all know this already, but essentially in any major emergency, there is the first wave, which is the, the wave in the context of a pandemic. There's the emergency itself, but typically the psychosocial burden itself appears later. It affects far more people in the actual event itself. And I suppose in the context of this pandemic, we were concerned that, we weren't just talking about the infection risk, we were also talking about the impact of the restrictions, and then we were talking about the economic impact that we all anticipate, that some of it's happening now and some of it's going to happen later. I suppose just quickly to mention that the second wave we have here in this diagram, that's about the change in the way care is delivered. That's something that people have spoken about already. It's something that we really noticed on the ground, and I might flag that in particular around the clinical programs. Okay, so I'm just going to really focus on the clinical programs element of it. The paper itself was broader than this, but this is the stuff I actually have access to data on. And I just thought I'd update you on where things are at kind of now. I suppose a lot of the clinical programs are focused on young people because they're in areas where we already have service deficits. And that's why there was a decision made nationally to introduce clinical programs to try and address these areas from a national perspective, rather than just relying on local service to do it, and for there to be an investment to support that. And I suppose we all know 75% of mental illnesses start before the age of 25. And so the clinical programs are largely in areas where the first episode of illness will be in young people. They're very focused on early intervention, supporting access, improving quality and improving outcomes. So I suppose young people have been particularly affected. I know it's interesting, isn't it? Different speakers will highlight different areas. And I think sometimes it depends on your context as well. I deal largely with young people. And so that's been very obvious to me. Another person who collaborated with us on this paper, actually, who I should have mentioned, is Dr. Michelle Hill, and she's a consultant psychiatrist in UCC. So she deals with student mental health. And so they were a group that we have been very concerned about, particularly its youth unemployment is dramatically affected more than any other type of unemployment, social isolation and also stigma. There's quite a bit of media coverage about young people doing this, that and the other thing, not following the rules and all of the rest of it. And I suppose a really, really vulnerable group in our population with young people are people who are not in education, employment and training. And the concern is this pandemic and its associated economic and social restrictions, all of that actually increases the cohort of people in that group dramatically. And that group is very significantly associated with suicide. So in terms of psychosis, I'll talk to my own service in Cork. So I lead the RISE service in Cork. It's one of the 3 EIP demonstration sites. We saw initially, March we saw a kind of no change in the number of referrals we would normally see. April, we saw a significant reduction, and then we saw an increase in May, and then into June, and actually in August and September, it's gone up much more. And in total, if you look across that 6 months from May to September of this year compared to May to September of last year, it's a 30% increase. That may just be an isolated thing, I don't know, but it is noticeable and it's quite striking. Talking to the other early intervention services, they're reporting similar type things. So that's something that we're hoping to look at properly in a systematic way and in a longitudinal way over time. We were seeing, and we are still seeing, more people being admitted at first presentation. That's because the pathways are not the way they used to be. So yes, we've moved into the community, but actually our community teams aren't necessarily resourced in the context of this pandemic to manage acutely psychotic patients in the community. So that's something we've been noticing as well. The impact of COVID on symptoms, yeah, we've definitely had quite a few people presenting with COVID-related symptoms, so believing that they caused COVID, having preoccupations about PPE, a lot of that. And again, that's something we're looking to look at longitudinally, not just in Cork, but across a number of services to see if there's actually really something in that. The other thing we've noticed is an increase in affective psychosis. So people who may have had an episode of depression previously never had any previous psychotic illness are presenting with a first psychotic episode. So either a manic episode or a severe depression with psychosis. And it's the affective group we're seeing an increase in more, and we're not fully sure what to make of that. And then the things that other people have noticed, it's been harder to engage people, particularly if they're admitted initially and then we weren't able to visit them in hospital, which we would normally have done. That's been challenging. And then the families can't visit them, and then they come home, and the family aren't as well informed as they normally would be, and it's all quite challenging. And we're concerned about the increase in suicide risk, but we don't have any data on that. In terms of the eating disorders, so the specialist eating disorder services across the country are reporting a 50% increase in referrals from July and August. So in July and August, they had a 50% increase in referrals. There's a change in the pattern of referrals as well. They're still seeing lots of anorexia, but they're seeing an increase in bulimia and binge eating disorders. There was some report out yesterday, I think it was about body image, and it kind of reflected some of that people were that there was a change in how people were seeing themselves in the context of the pandemic, which is interesting. Also, the eating disorders program are reporting an increase in acute hospital admissions because people are presenting more unwell. And again, they're out of touch with their GPs. They're not in the usual connections with people that they would be, and they're presenting more unwell. In terms of self-harm, I've just pulled CUH out of this because I had access to this data quickly. But one of the NCHDs in CUH with Professor Eugene Cassidy have reviewed all of the self-harm and suicide presentations in the last, I think it's about 5 years. But there was a very interesting finding. Again, it's potentially isolated, but it's an interesting pattern that between May and September of 2020, there was a significant increase in people presenting with suicidal ideation and self-harm compared to the previous summer. And so May to September. And again, of the people presenting, last summer, 15% of those presentations would have been admitted to hospital. This summer, 22% were admitted to hospital. So, and they're looking into this more, and they're trying to look at some qualitative data around it. But it looks like people are not as well connected in their communities as they normally would be. They're presenting later, and then they're requiring admission when previously they mightn't have. With ADHD in adults, so Jane covered ADHD in children very well earlier. ADHD in adults is one of the clinical programs. Essentially, there's hardly any access to assessment or treatment for ADHD in adults in Ireland. And so, and then the services that we're trying to get off the ground in the context of COVID, there was a lot of redeployments. The feedback we're getting from ADHD Ireland, who are the advocacy group who represent this population, they're talking about people having a lot of difficulty with disorganization, sleep disturbance, and difficulty focusing, or else actually hyper focusing, which I think we've probably all experienced in the last while. And then the last clinical program that I'll just flag is perinatal. There's been a lot of media coverage of this. The impact of the restrictions meant that women had to go to their 20-week scans on their own. They could have their partner in for the delivery, but then they weren't able to visit afterwards. And then when they go home, they may not have had family able to visit them. It's had a significant impact on some women and some families. The perinatal services are reporting an increase in severe presentations and having to admit people to hospital more frequently than they would have had to do before. And then that involves a separation of the mother from the baby and from the family. And then there's visiting restrictions, and it's very, very challenging. So I'm sorry, now I'm not ending on a very optimistic or positive note, sorry. But this is kind of, so this in the context of our paper, this is the stuff that's come out since then. I suppose it's just, I think we need to keep advocating, to be honest. I think we need to keep trying to keep, the mental health piece in the picture. I think that it is in the picture, but it doesn't translate to real increases in funding or resourcing of services. And yeah, that's my piece. Thanks, John.
Hey, thank you, Karen. Thanks a million. It's great to get the perspective from Cork, and you've touched on a lot further points there as well. I think it's been really interesting there. There's been a great summary from diverse regions of the country, diverse backgrounds in psychiatry. It's been really, really interesting. All the speakers, I'd like to thank them all very much. Now, Professor McNicholas might moderate the rest. We might have a little questions and answers. I realize now we've gone a little bit over. If people are interested, stay on for a discussion, and it might be nice. And I'll hand you over to Professor McNicholas now.
Great, thank you very much, and thanks to all the speakers. John, one thing is when the December issue comes out with our second COVID focused, we'll have to schedule a much longer discussion because You spoke about communication, Paul. I think that actually this has been a really nice way where we've linked with colleagues from around the country. We all know we're in our little holes working away, but so nice to see the positive as well as the challenges that no doubt we're going to experience. Paul, I was interested in the telepsychiatry and the huge benefits of an independent sector. You weren't stymied by the HSE advice of Zoom is on, Zoom is off, you know, this is on, you can't do that, PPE directions. So it's been tremendous to see a very well functioning organization anyway, just function even better at the time of a crisis. But in terms of telepsychiatry, and although people have managed to do it very, very effectively and 100% or more, do you think there could be a risk of, you know, in some ways asking too much of ourselves to expect to keep the show on the ground? There's no demarcation between home and work when you're working from home. The day spills on. The headaches you get at the end of the day from intense work because you're mindful of, is the person being coerced? Is this a good clinical assessment? The additional admin you have to do at quick time. You know, do you think that, you know, we should say, you know, certainly telepsychiatry as a space, but should we be expecting ourselves to work as prolifically or, you know, how can people stay healthy whilst working in this intense manner from home?
Oh, I think that's a really interesting and broad question, Fiona. I mean, I think you're absolutely right. I think we all know who have experience of it. And I think all of us do at this stage that doing things remotely is both more taxing and the well-known Zoom fatigue. We're organizing a conference next month, which is usually a day-long conference, but realized if it's going to be purely remote, it can only be half a day because people just, you know, you can't do more than half a day. And the same thing applies to individual calls, and you're right, the admin, etc., and that demarcation between work and life. I mean, I'm very clear that my work day begins and ends at a certain point, except for emergencies. I think at the moment, in a sense, we don't have a choice. I think it's going to get more interesting when we perhaps do have a choice, when the pandemic is over, which it will be at some point, how much of this we feel is beneficial, how much of it we still want to do. But I think at the moment, what we're concentrating on is trying to deliver as close to the same service to the same amount of people as we would normally do. But it does take its toll. I mean, one of my things earlier on in the pandemic was to make sure, I know this sounds off topic, but it isn't, was to make sure that my colleagues took their annual leave the way they normally would, and you know, not to be heroes, because we all needed, particularly when it was busy, to get away from it for a week or two. So I think these do pros, and I know, Fiona, you're a great proponent. Well, you're a great proponent of looking at telepsychiatry really critically, and that there are benefits of it. But I don't think we should be blind to this stress is not quite the right word, but the fatigue and the extra workload it involves.
Thanks, Paul. Colin, you mentioned a little bit about with the addiction services. The only addiction that I'd like to confess to, which I hope to keep after the pandemic, is that of watching my steps every day. Do you think that in some ways it's more, and this is for the whole group, it's about what good can we take from the pandemic that actually we should be trying to make sure that we promote during this time, whilst there is huge scare and uncertainty and distress for sure, but it's about maybe trying to also keep the positive very much in light.
I think there's an onus on us to kind of portray that, you know, and any opportunity we get to portray positivity. As Steve Peters famously says, happiness is a choice, you know. So I think there's so much bad and so much wrong about this. There's no point in trying to sugarcoat it, you know, but there are opportunities for people who suffer mental disorder and addiction. Mental disorder side of it, I think the isolation, there's probably not a huge amount, but there's a lot more people more qualified to talk about that than me. But from the addiction point of view, definitely, if people are not exposed to substances, this is like a once in a century opportunity for people to actually not be exposed to harmful substances, and in some cases maybe behaviors. And we're definitely seeing that within the context of our clinics, you know, people who come in, we're saying, look, you you can actually use this one opportunity, like Christmas coming up, for example. Like, people are actually delighted with the fact that they won't have all the normal pressures of Christmas. Although there's now a suggestion that people are going to go into lockdown for like 5 or 6 weeks and then go bananas like for December. So, but yeah, look, there are opportunities in there, Fiona, definitely, yeah.
Guys, unfortunately, I'd love to talk more to all of you, and just in the interest of your own time, I think, John, probably we need to call this to a close, do we?
Yes, yeah, absolutely. Unless anyone has any final things they want to talk about. I thought it was a really, really interesting afternoon, and thanks so much to everyone for giving their time. I certainly enjoyed it anyway, so I hope everyone did.
Well, do join us in UCD next Friday at 12:30, and looking forward to seeing you all again sometime soon. Thank you, everybody, and thanks to Blonid also.
Thanks, Fiona.
Thanks very much.
Bye all, thanks for organising.